Welcome to PharmaDocs with your host, myself, Dr. Jay Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Hey, John.
Jay, how are you?
Good. How you doing out there?
Oh, we're doing great, man.
Great.
Starting to warm up and getting ready to and just looking forward to a great spring, man. How about you?
It's been a little cooler. It's rained a lot, but it's definitely, you can see spring on the horizon. So I'm excited.
Yeah.
The next thing after that's summer.
Yes, we've had some rain and yes, summer and just expect it to be brutal like it is every single year here. All right.
Yep. Yeah. But at least I'll be able to jump in the ocean and go swimming. Right now, the water's too cold.
I love it, man.
All right.
I love it.
So let's see. We have got, actually, let me bring in the slides here. There we go. We've got a few new drugs. Now in we didn't do a show last month. And the reason was that there was only one drug that was approved in January of 2020.
Shocking, isn't it?
Yeah.
I mean, one drug.
Yeah. So we have it included in today's episode.
Yes.
What was I going to say? So now we have, was it 6 or 7 for today?
Correct.
They were approved in February.
7. That's right.
7. Okay. So let's start things moving. And we want to thank our sponsors.
Absolutely. Couldn't do it without these people. Thank them so much.
That make this all possible, including iCore Connect and their product.
Yes.
iCore RX is an electronic prescription system that will work from your computer, from your phone, from anywhere you are. And even if you're in, if you can get cell reception in the steam room, then you can, and your phone doesn't like doesn't mind being in a steam room, you can send some prescriptions from the steam room.
But Jay, think about them. They're into everything now. They're into claims and insurance, etc. I mean, just a great company to work with. Yeah. And so is this one.
Yeah, Fortune Law. When you think of a law firm, they're not representing dentists for malpractice. They represent dentists for everything else that is related to your practice. They help you with business, with investments, risk, minimizing any risk that you have, risk management in your practice. And it's a great group of people. They really understand dentistry. As opposed to some other like accounting and consultation services. Fortune Law really gets what we do in dentistry. And then we've got Vesper Institute.
Oh yeah.
Yep.
Where we just
home away from home.
Home away from home, where we just love getting you ready for IV sedation training. If any of you are interested, come learn it the Vesper way. Yeah. Jay and I are directly involved in the indidactic portion, our in-person didactic, excuse me, Jay. Yeah. And
we do that with Dr. either.
Yeah, we do that with Dr. I get so excited about this stuff, Jay. So we do that with Dr. Scott Sayre, and we just have a great online portion, then the in-person didactic, then we do a simulation training, and then you go into clinicals, okay? And you do clinicals with your fellow general dentist, okay?
Yeah, so it's not an anesthesiologist, it's not an oral surgeon, it's not a nephrologist. It's a general dentist who is trained and experienced in IV sedation, doing dentistry, general dentistry, and IV sedation at the same time. Is your one-on-one mentor.
That's right.
Yeah, because they're not nearly as intimidating as you and me.
No.
Yeah. All right. And then
we're not intimidating though, Jay. I mean, we're like the dentist. All right. I mean, if you want to come to us about, what do I need to do about this situation or that situation with oral surgery or pharmacology? We're here. Okay. We're practicing dentists like every one of you watching us.
Exactly. And then Balanced Pharma, which is coming out with a very interesting product that will change the way you do local anesthetic injections. They've developed a way to buffer a local anesthetic, but instead of having to draw bicarbonate into a syringe, it's a regular dental carpule that automatically buffers the lidocaine or the articaine or whatever you happen to have in the syringe, and it reduces the amount of injection pain significantly, and you've got a quicker onset. So it's going to be really a revolutionary product when it
game changer.
It's probably about 1 to 2 years away from being on the market and available, and we're really happy that they are sponsoring our show. So I guess there's some things in the news. This first one we've talked about before.
Yeah, but Jay, it keeps coming back, and I've just put some fast facts on there. So, Wegovy and Ozempic, they could complicate your surgery. Now, what do we mean by that? Well, we've already talked about doing IV sedation, so you got to have fasting guidelines, NPO guidelines, nothing by mouth for a specific amount of time. And Jay, there was a study that just came out that they did an ultrasound on patients before surgery.
Mm-hmm. Yeah,
people that were on these medicines, 56% still had gastric contents.
After the normal fasting time.
Normal fasting.
8 hours.
Yes.
Yeah. So, we talked about how these drugs work. And one of the things they do is they reduce or slow gastric emptying. They inhibit gastric emptying. And so they've found, just anecdotally, patients who had been NPO for 24 hours that went into surgery and still had contents in their stomach and actually regurgitated while they were anesthetized,
right?
And luckily they were intubated, or I think a couple of them aspirated. So this was a controlled study where they looked at this issue rather than just anecdotally. So it's important if you do IV sedation in your office or general anesthesia, and you have a patient who's on Wegovy or Ozempic or any of the new weight loss drugs, or if they're diabetic and they're on a GLP inhibitor, then you want to make sure that they stop using it a week before surgery. Now, if they're diabetic, it's hard to get them to stop. You got to talk to their endocrinologist about that. But if someone's taking it for weight loss only, then you want them to be off it for at least a good week so that they have an empty stomach when they come to your office.
That's right. That's right. And then, following the category, the FDA also approved Wegovy. All right. And we've talked about this drug several times on our show. We introduced our audience to it when it came out last year. Yeah. It has now been approved to help prevent heart attack and stroke in patients that have cardiovascular arterial disease, CAD. Okay.
Yeah.
Or
specifically those
disease.
Those who are overweight or obese.
Right. Right. Yeah. So they're the first drug in this category to get approval for coronary artery disease. Okay. Yeah. And so, these drugs are going to do so much for society. Okay. Because we've talked about this. We hit the 40% marker for obesity in this country, 40%. All right.
Yeah, that's a lot of obese people.
Yeah, and it's a patient red flag when they come into your office, period. Yeah. All right, because they've got other medical problems, okay?
Yeah, I had 2 patients come in my office last week who had BMIs over 55.
Wow. And that's a nightmare to put to sleep.
Oh, yeah.
Okay?
Yeah.
All right?
Yeah.
So the next one that's in the news is another Alzheimer drug, and the FDA made the decision to delay it because they just said more safety needed to take place with this drug before they released it. But it did have some positive attributes. It did show that it reduced the amount of amyloid plaques in the brain.
Right.
And,
well, the problem with that, just like the other 2 drugs that we talked about before, Aduhelm and Leqembi, is they also, and they're very similar drugs, and one of the reasons they postponed making a decision is because they couldn't really find any significant difference between this drug between the other 2. But they've been shown to reduce the number of amyloid plaques forming in the brain in Alzheimer's patients, but they've seen no clinical improvement with the use of these drugs, and they've got some really significant side effects.
And I know the company was very surprised to hear the ruling from the FDA.
Yeah.
And then finally, Jay, let's talk about the Z-Meds for sleep. I mean, Ambien, Lunesta, Sonata. And they just put a warning out for, to be careful taking these medications because people are sleepwalking, sleep cooking, and sleep driving, Jay. Houses are catching on fire because you're taking these medicines and doing things while you're under their influence.
Yeah.
All right.
And it's been a known problem for many, many years, but I guess it's getting out of control. There's so many reports now to the FDA that of these occurrences happening.
Right. And think about how many dentists, tell patients, hey, take one of these drugs before you come to my office the next day. Because, hey, you get worked up, you get anxiety. That's why we do teach IV sedation because, we around almost 40% of America have dental fear or dental anxiety, Jay. And so, hey, take this medicine, get a good night's rest. Well, sleepwalking, sleep cooking, sleep driving are all potential hazards of these medications.
Unless they're a really good cook, then it might be a good thing. I don't know. Okay. All right. Let's move on to our drugs. And the first one we're going to cover, we're going to go backwards this month. In opposite order of approval. So the latest one approved is Simlandi.
Yes.
And this is as you can see from the name, adalimumab. It is a human monoclonal antibody. And if you recognize that name, it's because it's a biosimilar to Humira.
Yes.
And not only is it a biosimilar, but it's what's called an interchangeable biosimilar, which means that the pharmacist can actually substitute Simlandi for Humira if they want to.
So bottom line on that one, Jay, whatever has the lower price or lower cost, that's what the pharmacist is going to go with.
Yeah. It'll probably be dictated by the insurance company. And so, this is
true.
This is, an autoimmune medication that is used for a lot of different autoimmune inflammatory diseases like plaque psoriasis, Crohn's disease, rheumatoid arthritis, ankylosing spondylitis, ulcerative colitis, plaque psoriasis, uveitis, and hidradenitis suppurativa is another one that it's a skin disease where there are these ulcers that form, or not ulcers, but blisters that form all over the patient's body that can be very, very painful. And it causes scarring, abscesses and scarring on the skin. So this is another drug, and hopefully, with the approval of Simlandi, the price of this drug is going to come down. And I'm sure there are going to be some other biosimilars that are going to be released.
Well, and some of the other similar drugs are Intovia or Intevia, all right, and then Taltz and Sotaiku as well too.
Yep. So be on the lookout for that. Again, it's a human monoclonal antibody. So the big thing that we always worry about with these drugs is the immune suppression that it's going to create in our patients to increase the risk of infection. So if you have a patient that you wouldn't necessarily always prophylactically give antibiotics to, a patient who is on this medication or one of these medications, these monoclonal antibodies, is going to have a higher risk of infection. And you also
an immunosuppressant.
And if you routinely give, let's say, dexamethasone as part of your IV regimen or Medrol dose pack, this is not a patient that you want to give a corticosteroid to, because that'll just make the immune suppression even worse. All right. Our next one, this is a combination antibiotic, and it is known as Exblifed. How's that for a name?
Yeah, Exblifed.
Yeah, it's cefepime plus N-metazolobactam, and so it's basically, think of Augmentin. So it's like Augmentin that has been approved, and it's a 4th generation cephalosporin that's used for complicated urinary tract infections.
So,
And
these are basically some of the more severe UTIs, Jay, that the regular antibiotics don't work.
exactly, the organisms are resistant to it. Who knows? Someday they may find that it's useful for treating oral maxillofacial infections. Who knows?
Yeah.
But
Well, so like
the first
you said,
indication the first indication it's approved for is resistant urinary tract infections, complicated infections.
So think about it. You got cefepime, which is a 4th generation, and then of course the imadatabactam, which is a beta lactamase inhibitor. And I love how you compare that to, like, say, Augmentin, and a great combination, but a much stronger spectrum right there.
Yeah, and more side effects and more cautions with it. Yeah.
Yes.
It can cause all kinds of problems, but the FDA approved to treat complicated UTI in patients 18 years or older, including kidney infections, pyelonephritis, and specific bacteria: E. coli, Klebsiella pneumoniae, Pseudomonas aeruginosa, Proteus mirabilis, and Enterobacter cloacae complex. We don't really see those organisms in the oral cavity at all, but is definitely effective against those. But it can cause, headaches, infusion side effects, because this is given as an infusion. It's not a pill the patient takes. An IV infusion that they run over 2 hours, 3 times a day for up to anywhere from a week to 2 weeks.
And Jay, like you said, there's so many warnings. I mean, we're talking about a big black warning on this medication as well, too. And,
including neurotoxicity.
Yes.
Exactly.
C. diff as well.
Mm-hmm.
So, and C. diff has been reported with nearly all antibiotics, Jay. Okay. Yeah. And so I know clindamycin always gets a bad rap for that, but pretty much C. diff can be caused by any antibiotic.
Yeah, exactly. And it can also, of course, you got to worry about it prolonging the prothrombin time, the development of drug-resistant bacteria. It can also, one of the side effects is it can give a positive Coombs test, which is a test for autoantibodies against the red blood cells that causes a hemolytic anemia, as well as false positive reactions for glucoseuria.
So, I mean, you got to ask yourself before you wind up taking this, but if this is all you've got left, then you've got to worry about these significant side effects with this medication.
Yeah, exactly. But for those cases, this is a new drug that shows a lot of hope for improvement.
Yeah. So I can only imagine these people with chronic UTIs. I mean, what their quality of life is like right now. So they're welcoming the opportunity to take this medication and forget about the warnings.
Yeah. And a lot of hospitalized patients will develop UTIs.
Yes.
That can be very hard to treat. And, it's interesting. A UTI, any kind of major infection, will completely turn a patient's mental status upside down. Correct. Patients can go from being normal one day to seeming like they're crazy the next. And so you always have to think about, do they have a UTI? Do they have a pulmonary infection?
Rule out fever, rule out infection, and so forth.
All right. So our next one is Amtagvi.
Amtagvi.
Lililucil. Okay.
Lifileucel.
Leafy. Yeah.
Leafy. Somewhere like
Let's call the whole thing off. So this is a tumor-derived autologous T-cell immunotherapy used for treating unresectable or metastatic melanoma. So this is an interesting treatment, because what they do is they actually remove tumor cells and they put them through a process. They separate out tumor-derived T cells and they grow them for about a month until they get basically a specific for that patient immunotherapy. And it's shipped back to the patient's doctor in 4 different IV bags, 4 different packets. And it's given to these patients over like a 6-hour infusion on 8 consecutive days. So
and Jay, think about look at how many cells are in each IV bag, like 100 to 125 milliliter of these cells are infused into each IV bag that you'll be given. Yes.
Yeah, millions. And of course, this has all kinds of side effects. Your typical, headache, flushing, hypertension, high tachycardia, but also it can cause grade 3 or higher cytopenia for weeks or even longer, or febrile neutropenia, cause internal organ bleeding, especially in the abdomen and skull. Not a good place to have that.
No.
Even life-threatening or fatal infections and acute infusion reactions, as well as worsen respiratory and kidney function. So this is not a drug to fool around with, or not a therapy to fool around with, but for those patients who have metastatic disease, metastatic
What choice do you
melanoma,
have? I mean, seriously,
you may not have a lot of choice. Yeah.
All right. I mean, again, it's nice to have these medications out there because multiple people, Jay, are going to respond to this therapy. It's going to save their life.
Exactly. It's going to save lives. Getting back to how we spot melanoma, we learned all this in dental school. Any skin lesion that looks asymmetrical, has kind of fuzzy borders, looks dark, large, and it may kind of evolve. It may start looking different, or you may get satellite lesions. Those are all warning signs of possible melanoma that need to be biopsied. And so you want to send, if you happen to notice this in yourself or a loved one or a neighbor or a patient, to get them right away to the dermatologist. And so if you look at some kind of normal skin lesions, normal, cutaneous nevi, with a melanoma, you have asymmetry, uneven borders, multicolors, as well as size greater than a 1/4 inch. And so those are all the characteristics that you'll see with a melanoma that should be red flags for all of us.
Jay, I always remember in residency, we were always taught the acronym BANS, BANS, back, arms, neck, and scalp are the primary sites for melanoma.
Yeah, which are sun-exposed areas.
Right. Yeah. But they can still occur in other parts of your body.
Exactly. But the risk is a little higher where there's sun exposure. Okay. So this slide looks pretty much the same. Okay, so we'll skip it. The next drug is
Aurlumyn, or Iloprost.
Yeah.
And Jay, this drug, wow. I was so interesting that when we were going through all of this, is for the treatment of frostbite, trying to help you not lose your digits due to severe frostbite.
Yeah.
And it's a prostacyclin mimetic, which is indicated for what I just said. Trying its very best to prevent any of us losing our digits due to, unfortunately, being exposed to severe cold weather.
Yeah, and what happens with frostbite is there's just a very significant vasoconstriction, because your body's trying to shunt blood into your central cord to keep it warm, and of course your extremities are cooling down the blood or almost freezing it. And so what this drug does is it binds to human prostacyclin as well as EP1 receptors, prostaglandin EP1 receptors, and acts as a vasodilator, relaxes the smooth muscle in the artery walls, and improves blood flow, and also inhibits platelet aggregation. And it's a synthetic analog of prostacyclin PGI2. So these are kind of the stages of frostbite. So the first stage is what's known as frost nip. And that's just sort of a mild frostbite that kind of irritates the skin. The skin is red. It may feel numb. It definitely feels cold. And then that will progress to superficial frostbite, which is just basically on the surface. The skin will feel warm, actually. And that's a sign of serious skin involvement. And the skin may actually start to form vesicles within 1 or 2 days of the skin being rewarmed. And then deep frostbite. That's the severe one. That's where digits are lost. That's where the patients will have complete lack of blood, lack of blood flow, ischemia to the digits, actually infarction of the tissue. and the patient will have numbness. The muscles may no longer work. The joints won't work. They may form, again, very large vesicles. And of course, the skin turns black because the tissue's dead.
Yep.
So this is a really interesting medication and something that's really needed in cold environments. And again, just like everything else, this has a lot of side effects. Let's see. And those include
headache, flushing, heart palpitations,
acute infusion reactions,
tachycardia. Yes.
Yeah.
But, Jay, just talking about the percentage of people that were involved in this study, I mean, a lot of them showed significant improvement in the bone scintigraphy anomaly, which is a marker that they used in the study to expect to predict the risk of amputation. All right.
Yeah. It's basically the scintigraphy looks at blood flow, and not just like an arteriogram, but actually functional blood flow. They use a radioactive isotope and put them under a gamma camera, and that's how they get the image. And let's see, it says that around
it's administered for 6 hours each day for 8 consecutive days. But you know what? If to save your fingers or your toes, I think you'll do anything you can.
Yeah. And of course, the key is, if you should observe this happen or happens to you, if you live in a cold environment, don't wait and see what happens. Get yourself to the ER right away.
Yes.
Because if you do have a 3rd or 4th degree, especially a 4th degree frostbite, the treatment needs to be started right away.
Yep.
Or you do risk losing your digits. And of course, as a dentist, that would not be a good thing.
Not good at all.
Yeah.
No.
And don't move to California. We have too many people here already.
I think people are leaving, aren't they?
A lot of people are going. They're going where they can afford to live.
Yeah, and Texas is warm. I don't think you have to worry about the frostbite. Every once in a while it'll get cold, but I don't think you have to worry about the frostbite.
Yeah. I was looking at some real estate, and for basically in like West LA, which is not it's not Beverly Hills, it's not Santa Monica, it's not Brentwood, a 3-bedroom, 2-bath house on a not great street, and the house is old, is selling for like $2 to $2.5 million. And for the same amount of money in Ohio, Columbus, Ohio, or Cincinnati, you can get an 8-bedroom mansion, with 12 bathrooms on 2 acres. It's just mind-boggling. So anyway,
so let's don't get into real estate demographics, right? Yeah. I don't think the audience cares.
Yeah, exactly. All right, so let's move on to the next one.
But if you want to spend that kind of money, Jay, go ahead. All right, okay.
All right, so the next drug is Ehilia.
Yes.
Genocide, which you can tell from the name if you've been listening to us long enough. That suffix ONID means this is a corticosteroid.
Steroid. Yep.
And think of it kind of like a Decadron rinse, except this is rather than just sort of rinsing it and spitting it out, this is a mucoadherent form of budenoside for treating eosinophilic esophagitis.
Yes.
And that is a very uncomfortable thing to have. It's a chronic inflammatory disease of the esophagus where patients have difficulty swallowing. They may not be able to swallow at all. They have pain, nausea, and it can cause stricture of the esophagus, which won't allow food to pass through or get stuck in the esophagus.
So think about quality of life there too, Jay, because you've got to cut everything in very small pieces. You've got to take your time, chew it, and then still have a difficult time getting it down the esophagus due to this disease state. Yeah.
And then you've got to watch very closely for the possibility of esophageal carcinoma.
Of course. Yeah. And look at the various pictures right here. Yeah. Okay. I mean, how the stricture occurs in your esophagus. And some of those pictures, I mean, you've got to make sure you have very small portions.
Yeah. But if you do, this is a or if you do develop eosinophilic esophagitis, again, don't wait till the symptoms are so bad that you can't swallow at all.
Right.
Kind of at the first sign of esophageal pain, go see your internist. It could just be reflux, and that's easily treated, but you want to make sure it's not something more serious.
Right.
All right. So for our patients who are using this, remember this is again a corticosteroid, so it's going to immunosuppress our dental patients that are coming in with infections or having dental implants placed or bone grafts. So we've got to be aware of this when we have a patient who says that they have used it, especially recently. And just like all other steroids, you have to patients have to be warned that they got to be careful of what can interact with this drug and throw off its blood levels, like a cytochrome 3,4 or cytochrome P34A, 3A4 inhibitors, including erythromycin that we may give our patients or other macrolides.
But do you ever write E-mycin?
No,
I've never written it. I've been practicing 26 years. Jay, I've been practicing 26 years, and I've never written E-mycin.
Yeah, period. I haven't either, but I've done some like Zithromax.
I've done Z-Packs, absolutely. But I don't see a reason why a dentist would need E-mycin. I really don't.
Yeah.
But you got to be careful about the side effects because of the CYP3A4 inhibitor that it is, because it's going to wind up increasing these concentrations in the patient's body. And guess who caused that? The prescriber.
Yeah.
All right.
Yeah.
Same thing. And tell them don't take it with grapefruit juice either.
Yeah. That messes with metabolism, the breakdown of a lot of different drugs.
Yes.
And so what can happen is the patient will start showing signs and symptoms of basically too high of a glucocorticoid level in their system. They may get adrenal suppression. They may have severe immunosuppression, which can lead to infections that can be really severe and even lead to death. So things like tuberculosis, measles, hepatitis, amoebiasis, fungal infections. So again, if a patient comes into your office and has what looks like thrush, you want to make sure you know all the medications they're taking. And if they're taking a corticosteroid, even if they don't, if they think they rinse with it and swallow, they may not think of that as taking a steroid. But it does obviously gets absorbed, and so that can be the cause of the intraoral candidiasis.
Jay, the other thing too is what you just said earlier about adrenal suppression, because when they come in and they're on budesonide and they're at this concentration, you've got to think about a steroid coverage.
Yeah.
And if you don't, then you could wind up stressing this patient out during an extraction or some type of invasive procedure. Now you've got an adrenal crisis going on in your office. Now you've got a medical emergency going on. Now you've got to handle that. So a phone call to their endocrinologist or whoever is prescribing
or their
this for
internist.
them, their internist, it is definitely warranted. And then what I always like to say, do a D3, document. Make sure you got all that down. Okay. So keep that in mind, everybody, about this medication as well, about adrenal suppression, because we're always so used to, you're on prednisone, 10 milligrams for, 2 or 3 months in a row. All right. You're on a daily regimen. Well, this is not prednisone. This is budesonide. Okay. But this is one of their side effects.
Yeah, they all cause some suppression, some adrenal suppression, which you have to account for if you're doing a procedure, even if it's a simple filling. If they've recently been on a high dose of steroids, like within the last month, or if they've been on chronic for more than a couple months. You got to supplement them with some more. All right.
But Jay, it also besides that, it's also highly immunosuppressive as well. So you got to cover them with some antibiotics.
Exactly.
You got to remember that.
Yep, for sure. So I mentioned the serious side effects already, so we won't go over those again. but those are definitely serious side effects from this drug. And the last drug we're going to talk about is Zelsuymi. Right? Did I say that right?
You said that right.
Zelsuymi,
Yeah.
which is a nitric oxide.
Berdazimer.
Yeah.
I like Berdazimer, Jay.
Yeah,
all right.
All right, you call it that. Zelsuymi is easier.
Yeah.
So it's a nitric oxide releasing agent that's used for topical treatment of molluscum contagiosum in adults and in pediatric patients over 1 year of age. And this contains two different gels that are mixed together.
Yes.
And molluscum contagiosum is basically a skin rash that you'll see looks like this. And it's a very contagious disease. And for kids, it's very transmissible, and probably one of the most common modes of transmission is through swimming pools.
Right.
That, kids are in the pool that may have this and not be aware of it, or the parents aren't aware. It thrives in warm water. So swimming pools and even bathtubs from one kid to the next, if you have a couple kids, can transmit this. In adults, it's a different story. It's usually considered to be a sexually transmitted disease from skin to skin contact. And the way this works is patient gets two different tubes with a dosing guide, and they basically apply the berdazimer gel, and they mix that with a hydrogel in a specific ratio, and then they put that. It's a topical medication. So this is again, a medication that we need to know about, especially if we have kids and we suspect molluscum. We definitely want to get our kids to their pediatrician ASAP and get them on this. All right, so that brings us to our
medical emergency of the month. Need to have we need some type of great voice right there that just shouts it out, Jay.
Medical emergency of the month.
Hey, I like the way that sounds. Now, of course,
actually, this is for 2 months.
Yeah,
we weren't here last month.
We always say this could happen anytime, at any day, in any dental office, because none of us,
anywhere.
None of us are immune to a medical emergency, Jay. I think we have gotten so used over the decades of someone saying they're rare or this or that. But then again, you and I see headlines every week. Mm-hmm. Patient dies in this office, or dentist sued for $3 million because of patient death and so forth.
Yeah.
So these are more than likely offices that weren't expecting it. They thought everything was rare, and they were not prepared. And unfortunately, a negative outcome occurred in their office.
Yeah.
So I try to tell everybody, and I know you do too, go ahead and get the mindset that you are going to see a medical emergency in your office, and be ready for it, period.
Be ready.
Yeah.
Even if you don't give IV sedation or general anesthesia, even with local anesthetic, you're going to see medical emergencies, including
the local anesthetic, Jay, is a serious surgical intervention. Why? We just put a needle in someone's mouth, gave them a solution that, Jay, it doesn't work just locally. It works systemically as well too.
Yeah, it does get absorbed, especially if it doesn't have epinephrine.
And you know what? I like what you just said earlier too. It can happen anywhere. I mean, it may happen at the ballpark, or at the stadium, or at church, on the airplane. You have the opportunity to save someone's life. All right. Learn this the best you can. So some of the signs, Jay, they're symptoms that we'll see: sudden, difficult breathing, wheezing, chest tightness, shortness of breath. So all of you out there right now, what is happening in your office with this patient?
And usually this patient will have a history of this disorder. That's of course, an asthmatic attack.
Right.
And so just like every other medical emergency, you want to stop what you're doing right away. If you've you're doing something that causes bleeding, like you're doing an extraction or something like that, you've got to pack off the area so that the blood doesn't go down the patient's throat while you're trying to deal with the asthmatic attack. Because if they aspirate that blood, that's going to make things even worse. What I do in my office, and I would recommend, even if the patient's awake, we do this, after sedation, after we finish a GA, my pack, I take a 4x4 and I wrap two 2x2s into it and roll that up into a ball the size of a walnut. And the key is I have a tail about this long that's sticking out of the patient's mouth. So I can always see that pack. Because if you just pack the area and you, let's say, have to give positive pressure ventilation or something like that, you don't want that pack to be shoved down the patient's airway. No.
Jay, there's plenty of cases out there where a 2x2 gauze got on the vocal cords. The patient died in the office. Okay. And so, I do the same thing. Bottom line, your patient looks like a walrus if you do this correctly. All right. The tails will hang out through here, and they're there for a reason for you to pull those out in an emergent situation as well too.
Yeah.
All right.
And so with an asthmatic patient, you don't want to, like with other medical emergencies, lay them supine. You want to let them kind of sit in the most comfortable position for them, which is generally sitting upright. And of course, you got to go through your ABCs, airway, breathing, circulation. And should they stop breathing, you've got to be ready to do rescue breathing for them. And if you don't feel a pulse, if it gets really bad, you've got to be prepared to be, to do CPR. The treatment, for an asthmatic attack is usually pretty simple. And usually the patient will have an inhaler with them because they get asthma attacks and they know what to do. But again, if they're sedated, they can't do that. Or they may not have had an asthma attack for a long time, and so they don't carry an inhaler. And in your office with the stress of being in the dental chair, that may initiate an asthmatic attack. So you got to make sure that part of your emergency kit is an albuterol or a bronchodilator, albuterol inhaler.
So, and Jay, this is critical. I got contacted one time to represent a case where an asthmatic attack went bad, patient died. And I asked a simple question. Did the dentist have albuterol in the office? And the answer was no. I mean, Jay, that's one of the core 8 drugs. You got to have that. Okay. Yeah. So this dentist probably had the mindset again, it won't happen to me. Right. Well, an asthmatic attack did, a patient died. And, I told them I wasn't interested because I don't see how you can defend a case like that. All right. Period.
I would agree with that. And and you also have to have, in case the albuterol doesn't work, you've got to have epinephrine.
Correct.
Because that again,
now you got refractory asthmatic attack going on.
Yeah. And you've got to monitor the patient's vital signs closely. If it doesn't break after, let's say, a single dose of a single inhalation of the albuterol, call 911.
Jay, I want the audience to hear us here. We've treated so many patients over the years, so many asthmatics. One way to prevent this from happening into your office is before you treat this patient, have them bring their inhaler, have them take 2 puffs, have it witnessed by your staff before you do treatment on them. Yeah. All right. They are now bronchodilated. I am here to share with the audience, I've never had to treat an asthmatic attack at my office because of that preventative measure that we take on all of our asthmatic patients. Yeah. Okay. So two guys right here sharing our knowledge with y'all, and probably treated between the two of us 100,000 patients.
Yeah.
No asthmatic attack.
One of the best ways to manage a medical emergency is to prevent it from occurring in the first place. So,
if we can prevent it, okay, but you got to do everything you can.
And this is a case where we can.
Yeah.
The pre-med, and we actually have a whole big bag of spacers in the office.
Yeah. Yeah. And Jay, I just want to tell everybody, like as you read down this right here, this is a quick reference checklist. Okay. All offices need to have that. I hear people, well, I'll just go grab a medical emergency book and look it up. Let's think about that, Jay. Yeah. Well, first of all, we got to find that book, right? All right.
Yep.
And then you got to have staff members trying to turn to a page and find the right algorithm for you to follow with corrective action steps, right?
And by the time you get there, it's too late.
Too late. Or, I hear a lot of people talk about, hey, open up this app. Hey, I'm all for people making themselves better, whether it be a book or an app. So if that app is on your phone, where's your phone during this emergency? Does your staff know the passcode? Will you even remember your passcode because you're in a stressful, chaotic event right now? And sometimes it can be an emotionally charged event that we forget simple life-saving things. You might forget your passcode on your phone. Then when you do that, you got to find the app. All right. Then you got to open the app. What if your phone's not charged? What if your internet's not working that day? Okay.
Yeah. What if it just doesn't load properly?
Correct, Jay. So, again, I'm all about people learning before the event, but it's nice to have charts like this quick reference checklist right there in your operatory. This is an asthmatic attack. Your dental assistant reads through this so you don't forget everything. Yeah. Okay.
Yeah.
All right.
And if you do have the app, a good way to use it is if you're sitting around, you got nothing to do, you're waiting in a doctor's office for 15 minutes. Go through it. If you're waiting to get on a plane or you're on the plane, then review it so that it's always fresh in your mind.
Jay, you and I do this. We want to see everybody have great outcomes when an event or a crisis occurs in your office. But like we said, every week we share different headlines that are shared from other colleagues. You just have to wonder, was that an unprepared office? And probably, Jay, 99% out of the time they were.
Yeah. It's quick recognition and quick action.
And then on top of that, Jay, there's a great chance you're going to lose your license. You're going to lose your office and all that, all because you just wouldn't spend a little time getting ready. And, to two guys that are out there trying to make it better for everybody, that bothers us.
Yeah.
All right.
Yeah. We don't want anything that's avoidable to happen to you in your office.
Right.
Some things you just can't avoid, and some things just can't be treated. But there are plenty of emergencies that you can treat. And like I said, if you recognize it, intervene quickly, you're going to save that patient's life.
Jay, I think about maybe a pulmonary embolus or an aneurysm, whether it be brain or aortic abdominal aneurysm. Those are something that, that was just an unfortunate situation. All right.
Yeah. Yeah, exactly.
But these other ones we can do something about.
Yep. Okay. So
what happens?
You all remember this from dental school.
That's right.
With a normal state, the muscles in the airways are relaxed. There's a normal amount of mucus, but with asthma, the muscles tighten, the airway constricts, it swells on the inside, which reduces the airflow, and the patients have difficulty moving air in and out. And I think I've mentioned this before, is if you see someone who's having an asthmatic attack and they're really struggling to breathe, you see use of accessory muscles, and they're really working. You're seeing the abdomen extend to try to get air in and out. That is a sign of imminent disaster. Because what will happen is that's a lot of work. The patient is going to tire out and then stop breathing altogether. So that's why, quick action is necessary in all these.
Right. Because wheezing is not a good sign with an asthmatic attack going on.
No.
Okay. Wheezing is not a good sign. It's going to get worse.
Yeah. Unless something's done about it. All right. So I guess this will kind of wrap up our topics. We just want to remind you again of our IV sedation course. at Vesper Institute. So it's vesperinstitute.com. That's
we
pretty easy to
love
remember.
to have you. We are engaging. We are passionate. We love what
Yeah.
we do. We want to share that with you as well too. This is a non-intimidating environment. Okay.
Yeah.
I mean, our last class, we absolutely just loved everybody, and it was just great.
Yeah.
All right.
And in addition to our course, there are plenty of other courses there on restorative dentistry,
Oh, yeah.
implants, bone grafting, courses for assistants, aesthetics.
The
You really should
Midwest
check it
Center
out.
for Dental Education, Jay, bottom line. Okay.
In Cincinnati.
That's right.
Where houses are portable.
Yeah.
We've got a number of courses on dental learning. One that a lot of people are taking is the opioid course.
Yes.
Depending on what state you're in, it can be a 1 hour, 2 hour, or 3 hour course that's required. And this is a 3 hour course to cover all of them. However, if you're in California dictates that the course has to have a specific name and be only 2 hours, and whoever
Of course
has to be approved by the board, which I am. So we have a separate course for California, but this is a great course for satisfying your opioid prescribing or opioid education requirement for renewing your board.
Are you going to make that course more expensive in California, like the real estate?
I don't know. Got to talk to Aldo. All right.
And then we got the latest and greatest in anaphylaxis update 2024. Okay. And so look, this is for everybody in the office. If you want to learn more about anaphylaxis for about 2.5 hours of CE for $29 on dental learning. Okay. All right. I cover everything with anaphylaxis.
Such a deal. And then we've got plenty of other courses too. So check them out on dental learning. Our next installment will be next month, April 12th.
Yep.
Same thing. Second Friday of the month at 3 p.m. Pacific time, 6 p.m. East Coast time. And we'll go over all the drugs that were approved in March this month, as well as some news.
That's right.
And a new emergency. So
Yep,
we hope you can join us, because we'd love to have you logged in on our podcast and be part of us.
Yeah,
so,
it means a lot.
Closing
for
words,
us
John?
Yeah, I'd just like to say it means a lot for us to spend your time with us because your time is valuable. But we're trying to research all of the latest in medications that are being approved and how it can have dental implications to your practice. Okay.
Yep.
And I mean, go back, and we've been doing this now for about 3 years. We've got a great log on dentallearning.net. And like Jay said, we've got so many other courses there. Jay's got a great video called DOMES, Dental Office Medical Emergencies and Simulations. And he just does 5 modules on there. Very great job on that. We've got mock drills, both adult, pediatric. We've got airway emergencies. We've got sedation emergencies. We've just got you covered if you're having a hard time finding a lecture somewhere, whether it be state, regional, or national. All right. And the great thing, Jay, about this stuff, including our pharmacology update, which we cover 15 different medication categories, you can reference this for the entire year. Whereas, if you go attend a course, Jay, what happens after going to a 3-hour course? 6 hours later, you forgot about 75% of that material.
Yep.
All right.
And you can't take notes on everything.
You can't.
It's
and
impossible.
You can stop our lectures anytime and go back to everything. I just think it's a great way to keep you prepared on both medical emergencies and pharmacology.
Absolutely. All right. So with that,
I'll see you next month, Jay.
We'll bid you adieu for now, and we'll see you on April 12th.